Maverick Physical Therapy. Welcome to what I'd like to call maybe just trying to define and struggle and battle with myself in terms of how I would and where I would place this episode in regards to our differential diagnosis and diagnostication episodes. I feel like it's an intro. I feel like it's a conclusion, but yet as a conclusion has it's finished but never done. That's how I like to kind of think of it. Um, but I want to spend a little bit more time in this area with my strategy being I want you as an individual to be able to be as prepared as possible to take ownership of your health care, and being able to being able to reason and make decisions for what's best for you as an individual, um, better than anybody. And so I think it's really important today as clinicians treating patients and helping them, being able to move better and help them, being able to take ownership of their health, that we provide options, but that we also have um, a big funneled kind of system in which we're able to really listen to the patient, and that we have a genuine and authenticated heart and spirit that really wants to be consumed by this individual story. So we have some really brave and some really cool people that are willing to share their stories a little bit with us in regards to some differential diagnosis. And again, as being a physical therapist, a doctor of physical therapy and applied functional scientist, that doctor in the front of the name resembles and represents primary care physician of the musculoskeletal system. It means that, and you're probably wondering why I'm having a leg in my hand, besides the fact that I really like the foot and find it really complex and unique, and the start of kind of this domino-like effect we call movement throughout the rest of the body. The bottom line is that we need to know how things work. We need to know how everything works together with regards to joint structures. We need to know about bones and its motion. We need to know about all connective tissue between all the fascia, the muscle bellies, the tendons, the ligaments, the joint capsules, and we need to know about all of that at once as it's happening in motion. So we need to be able to, if someone presents with a problem or just simply has a lot of goals and aspirations in terms of which they want to meet, to be more efficient, more consistent as a mover in life, whether it's occupational, recreational, or a combination of both, we need to be able to construct and be that clinician that can put the best blueprint together in regards to that person's plan and purposes defined by the assessment that we produce and put together and built on the principles and the truths that we accumulate, strategize, and then implement with some techniques. So the current state of our movement industry and of our healthcare system and in the rehabilitation world is quite complex. There's a ton of stuff to go through and to filter out. Everybody is offering some form and way in the fitness industry to get better, kind of feeding off of some form of marketing strategy and some form of fad. And it's really easy to get sucked into that, whip out the credit card, and continue this vicious cycle throughout the decades, paying out money, whether it's for some form of equipment that offers and greatly explodes that hey, you're going to receive a certain benefit within 4 or 5 weeks of 3 sessions a week for 10 minutes of this. A lot to kind of to wrangle ourselves through, and in the health care profession today, we've got a lot going on in regards to skyrocketed premiums, skyrocketed co-pays due to a lot of the Patient Protection and the Affordable Care Act, which then unfortunately provides kind of a watered down system of care in which you have clinicians seeing a significant higher volume of patients due to a much lower reimbursement rate. And it shouldn't be about that. It shouldn't be about the reimbursement rate. But unfortunately, that's really taken a hash in terms of how individuals are being reimbursed. But no excuses to that. We need to know the game. We need to know the system. And first and foremost, we need to take care of the patient. Second, we need to play the game. We need to know the insurance system and the insurances inside and out via the documentation that we provide for assessments and revisits, and being able to properly strategize and put into words our finding in the most functionally purposeful way, but yet that plays the game in regards to the insurance system that is in the best interest of the patient, because we have people looking at our notes and individuals that have nothing to do with the healthcare field and that are looking for certain key phrases, words, and certain standardized assessments that aren't very purposeful, aren't very functional. B decided to join on in. So we're confronted then, oftentimes whatever kind of medical clinician we go and see, typically we spend very, very little time in there. We've got a clinician whose head is buried into some form of computer, in some form of system in which they're typing away. As we're going and probably checking a whole lot of boxes and other things, just to meet the demands of what is being placed on them by whether it's the group they're with, the company, etc., to meet the demands of being reimbursed properly and in a timely fashion by the companies. A lot of problems with that is that, okay, we don't have very much time, and we're a lot of times basing things off of a textbook in terms of what we've seen and what we've heard previously, in terms of maybe whether it's an anatomical location, and we start to categorize some of these symptoms without doing assessments, and then making our calls and judging one based on that. And that's a problematic thing. So in regards to differential diagnosis and being that diagnosticator, the diagnostician, we need clusters of best exam findings to enable us to say, hey, this is the tissue-specific impairment that we have gathered, and based on the evidence that we have hunted and gathered from the movement-based assessments that we have performed, which were originally hypothesized based on this interaction and conversation that we had initially being in that assessment to find out if there was a mechanism of injury, what exacerbates and alleviates the factors, and when things are better, when things are worse, or someone has previously had that. So we get really lost, or the patient gets really mixed in the shuffle, in that they're oftentimes not given a significantly accurate medical or rehab diagnosis, and is provided basically an ICD, used to be 9, but an ICD-10 code, which is basically, hey, reimburse us our money. So for instance, a cervicalgia, neck pain, well, for crying out loud, there could be 2,000 things that create neck pain. Lumbago, low back pain, okay, wow, 3,000 different things. Patellofemoral syndrome, okay, 5,000 things. Rotator cuff syndrome, or adhesive capsulitis. You always have to laugh when you receive these prescriptions in the clinic from medical doctors and from others, and that it's so generalized and non-specific, and usually very, very far from the truth. So we need to realize that we're much more and much different than this cookie cutter like programming or system that that we're kind of getting forced upon us.